injectable antipsychotics. Although we planned this a while ago, the timing is perfect because what I'm going to do is talk about three studies that have come out all in the recent weeks. In fact, so very up to date information. One of those studies, I'm happy to say, came from the Summit County area through Community Support Services, the ADM board, and help statistically from Kent State. So at least it'll be also relevant that way. I do want to give some quick acknowledgments to CSS, as I just said, and Kent State. And then actually there's a long-acting injectables in jails subcommittee that both Dr. Messamore from Neomed and I are on, along with Justice Stratton, Dr. Tilley, a whole bunch of other people. And so we gave a talk a period ago, and I'm going to pull a few slides from there, which is why I wanted to give some acknowledgement there. So you're going to get the slides that I won't belabor the first slides. You all know this, but just by way of introduction, what is psychosis? And of course, the biggest problem with the psychotic illnesses often is anosognosia, which is lack of insight. And that's one of the reasons, and I'll go through that, why once a person is amenable to a long-acting injectable, that we often see overall benefit, even if they retain their anosognosia, but at least an experience through our assisted outpatient treatment program where people may be on these for longer periods of time. And all those clients in our county, our CSS clients, we see that improve. We do see some insight improve over time. We think of psychosis as a dopamine illness. And you've heard many, including Dr. Messamore, even talk about, we may not have that completely correct. There may be other mechanisms. There's probably something like 8 types of schizophrenia, but, our behaviors can only display themselves in a few ways. So similarly, one virus may cause you to have certain symptoms and me to have different symptoms. But if you looked at everybody, you'd say, aha, there's a list of symptoms that are consistent. Schizophrenia, therefore, may be a bunch of different illnesses, and they're not all related to dopamine. Hence, we have a certain percentage who don't respond even to long-acting injectables that are currently available. I did see there is a new medication being tested on the horizon from the Boehringer pharmaceutical company, privately owned actually by two families, I guess, that may actually work on some of the cognitive issues for schizophrenia, which would be a first. So that is something else coming down the pike just while we're talking about current studies. National Institute of Mental Health says it's about a 3% lifetime incidence of psychosis. So that's a lot of people. And as we think now, lately, we've been counting the number of people and then percentage who end up getting a COVID vaccine. You start to get a better sense of the country's population in ways that we otherwise wouldn't have necessarily thought about. Even Ohio's population, what percent, and so forth. So 3% of 300 plus million people is a lot of people who may experience psychosis. We do a lot in Summit County and the region around first episode psychosis, a whole another talk. And then I want to mention inmates because that's part of what we're going to talk about. They tend to be diagnosed with serious mental illness and serious and persistent mental illness much more than the general population. That is, there's a selection bias of a sort that those who end up in incarcerated settings, more of them have a psychotic illness than the general population. So it's often in the neighborhood of 16 or 17%, depending on the study you see. So that's a lot of people in those settings that need help and need care. And we are working towards having more of them once they're tested and not having side effects from oral medications, to also shifting them to long-acting injectable antipsychotics. So previously, if you think about the treatment, we talk, when I was trained, it was all compliance. We've tried to go to a kinder, gentler term, adherence to medication, to the plan. So more of an agreement, more of a shared decision-making process that I always say, Mr. Jones and I agree that this is what he's willing to take. Here's his regimen, here's his schedule. And we try to go for that. Even that shows not as much adherence as any of us would like to see. When they do studies on even physicians and their medication adherence, it's also not anywhere near 100%. So we should just keep in mind, as we're going to talk about long-acting injectables, it isn't just for people with psychosis. and I always say, only half jokingly, if the drug companies would come up with a long-acting injectable Prilosec, I'd be really happy to take that shot a few times a year and not take a pill every day. So adherence is an issue for all of us, but it is often what studies focus on, comparing oral medications, particularly antipsychotics, to long-acting injectable antipsychotics. The other thing is, from other studies, that if you don't take your regimen as prescribed, assuming it's the right regimen and the diagnosis is accurate, then you're going to have more likelihood of relapse. Again, that's for physical as well as psychiatric illness. You're going to have more worse health, worse outcomes, more hospitalization. Looking at it from the other angle, increased costs. That's not a good thing. And actually, from the incarceration point of view, you get more violent and nonviolent offenses when people are not adherent, particularly to psychiatric medications. So long-acting injectable antipsychotics that have been around a long time now, actually, the first generations, and I'll mention those a little bit in a minute, and the second generations have often shown in the studies that they do improve treatment adherence. Obviously, you still may get into an issue as somebody who says, nope, I know I took the shot the last 3 months in a row, but I'm not doing it now. We actually had a case conference on a challenging individual in Summit County earlier this week for exactly that issue. Had the sheriff involved in the meeting, had our probate judge involved, had the treatment team, had the guardian for the individual. The individual refused to show up at the meeting, hence the problem. And so we're trying to figure out how to not have 3 sheriff's deputies drag her to the hospital once a month for her shot. That's not good. Although when she does get it frequently, she does better. So just because you are saying, hey, here's an idea, let's make this simple, don't take a pill every day, doesn't always mean that that works. And in her case, as a good example, it's anosognosia. She doesn't think she's ill, even though she does end up in the hospital with great regularity. So all of our systems in Summit County know her. Even that has not helped her to see that she might actually have an issue. So a lot of issues here, of course, when you look at the studies, they talk about when you take an oral medication, you're going to have a period of time where it gets into your bloodstream and reaches a peak. You're going to have a time period where it starts to drop away, the half-life. Long-acting injectables tend to show a more stable blood level. And from a scientific point of view, it makes sense that your brain, your neuroscience components there that all of us have learned about are going to be more stable, right? Your brain is always looking for homeostasis, looking for a balance. So if you've got a constant blood level, therefore constant brain level, you're going to actually, over time, tend to do better in terms of the medication helping you with your illness. There's a lot less issue, of course, with overdose, right? So in terms of my thinking from a forensic point of view, you're less likely to end up with any liability as a clinician if you're given the medications in pill form and then they can't remember if they took it the last 4 times and then they take all 4 doses together. That kind of outcome is also a problem. So here's a quick chart. This is the only one that's on the quiz. Not kidding. All right, so that's just a quick chart that shows you the main ones that we use in the United States. There are a few used in other countries that we don't use here. They've not received FDA approval. So you're seeing the main older ones here, the fluphenazine and the haloperidol. And these are used, we still see Haldol, haloperidol used with some regularity at community support services, for example. Not as much, though. It's about 10% of the population there who get LAIs get Haldol. The vast majority actually have moved on to the sort of the progeny of Haldol. So Risperdal, and then really now they're getting paliperidone, which is Invega Sustenna. The only one on this list that is longer acting is Invega Trinza. That, as you see here, once every 3 months. And our experience, we've got a pretty good number of individuals over time now in Summit County, again, almost always through community support services on Trinza. And the outside observers, if you will, frequently will come to me and say how much better people are once they are on Trinza. And one of those happens to be Judge Stormer, who's a very, very good judge, sits on our probate bench. And she and I went back and forth on this one time. I said, well, they've got to be stable for 4 months on their Invega Sustenna, so monthly shots for 4 months before they start the Trinza. And so, of course, they're more stable. You get them on Trinza. She said, no, That's not what I'm talking about. She's like, I see them in court, and after 2 or 3 shots of the Trinza, so you're talking months now, they're completely normal people. I mean, she sees them laughing, joking, telling good stories, telling them they got a job. She talks about a couple of particular, one man and one woman. She's seen them complete sea change. Both were individuals she used to see when she was on the criminal bench. So she's really seen their life change for the better when they ended up. So there are anecdotal stories, but let me go now into the studies, because obviously we'd like to be evidence based and see what those are. So you'll see here Lancet. So this is the biggest or I guess most reputable journal that's in Britain or in UK. So April 13th, this is practically brand new, hot off the press. So they did look at a meta-analysis. So they looked at a bunch of different studies here, and they're comparing oral versus long-acting injectables, in this case, antipsychotics, to sort of see how this played out. You'll see a lot of records across all of the studies. You'll see where they chose a lot of the studies, not all of the studies, met the criteria. They had randomized controlled trials. They had cohort studies, and they had pre and post studies. So each of those being a little less salient in terms of how strongly you can say, yes, we found something here that's important. So the randomized controlled trials, still the gold standard, but they saw a lot of studies and they wanted to include that. And the data I'm going to give you breaks that down based on the types of trials. So for time's sake, you'll get the whole slides that I highlighted some things here. But you'll notice that people that get the long-acting injectables have a lower risk of hospitalization or relapse than if they're taking oral antipsychotics in any of the study designs. So that's pretty significant. So no matter what kind of study you do, it shows this significantly. So that's very, very important. So if there's a singular takeaway from this study, it's probably that, because it hits all of the types of studies, the simplest up to the most structured, which is, again, the randomized controlled trials. That's the RCT. All of the other outcomes, you can see the LAIs were more beneficial than the oral antipsychotics, but not in every study, right? So you've got effectiveness, efficacy, safety, quality of life, cognitive function. 60 of the studies did in fact show that the LAIs were better, but 252 did not show that they were better. And actually 16 said they were less beneficial. So, and again, it depends on study design, but that's why I say the takeaway is probably the lower risk of hospitalization or relapse, because that held true in all of the studies, no matter what type it was. That's a strong statement with that many studies being looked at. So again, every study may be a little different and the statistics may not be perfect. You never know if the design's exactly right and so forth. Here's another one. This is also, again, I went from then to more recent. So May, this month of 2021, this just came out as well. This is looking at the antipsychotics and mortality, particularly suicide, but then all-cause mortality with individuals who are newly diagnosed with schizophrenia, which again is generally the diagnosis people have who receive LAIs, but you have other psychotic illnesses people will get these for. I actually just heard yesterday a story about somebody in the emergency department at Metro Health where I was surprised, and I need to read into this more, that they, for that type of individual who was not doing well psychiatrically, but really there was some physical stuff, probably some delirium going on, they actually gave Haldol decanoate, but the lowest dose. And I was shocked that an ER would do that because it had nothing to do with his normal treatment. So there obviously are other uses that maybe emergency room doctors have found that is a literature I've not had a chance to explore. I literally just heard it last evening, so not that helpful for today. So they looked at, this is JAMA, so that's our most recognized medical journal here in the United States. We had Lancet, now we have JAMA. So over 2,600 patients with schizophrenia switched from oral to long-acting injectables, and then they matched controls to them. All right, so you've got a control set up here. They followed them for 16 years. So I'm thrilled they published this right before this talk, since it could have happened anywhere for the last 16 years. They could have decided to stop the study and do this. And again, I highlighted, just because of the timing here, I highlighted this. You'll notice they used some insurance databases here, and this is focused on Taiwan. It's a single payer, i.e. universal healthcare system. And so almost everybody, 99% of the people in Taiwan, which is a relatively small population, obviously compared to the United States, not even 10% of us, but it was very well studied. They have the data, very firm data on all these individuals. And you'll notice the newly diagnosed individuals, quite an age range here. It's a little surprising in our country to see as many newly diagnosed, anywhere close to 39. So this is Taiwan. There may be something different there that I don't know about. You'll also see that all-cause mortality rates, right, are much higher, 1.5 times higher almost in the oral antipsychotic group as opposed to the long-acting injectable. So that represented ultimately, when they did the Cox multivariate analysis, 37% lower risk of all-cause mortality. That's quite significant. Again, during this 16-year period. So that's a pretty big significance. You'll notice also the lower risk of suicide attempts. So with long-acting injectables, certainly a great measure. Our country, the United States, again, a whole nother talk, is one of the worst in the world for death by suicide in terms of number of people per 100,000 per year. So this is significant in a population that does have a higher risk of suicide than our general population, even in the United States. And then a 47% reduction in the risk of suicide mortality as well. So they really drilled down on this and are showing very powerful effects. Again, these studies are too new to be in the meta-analysis that I showed you first, but very powerful effects of these long-acting injectables. And then sort of jokingly, my favorite study, because we did it, myself and colleagues did this one, but it just got published. I'm thrilled to say it. A much longer process than you would think getting these things published. And I do on each of these slides, by the way, have the citations so you can pull them up if you wanted to look at them. And of course, I've got the full PDF of this one if you're interested in that in particular. We were focused on criminal justice system encounters. Given my forensic interest, that's the first thing we went after. There may be other ways we will break down the data for future analysis, including substance use disorder, which we've looked at and done a poster on at one of the national conferences when you could go to such things in person. So that, again, that gives you a sense of the time frame of getting this published. But so the gist of this is, and I'll go through these fast, but you'll see them. I've got more of these slides than the other ones because we've got these from the study. But so this is a retrospective analysis. So we were looking backwards in time. It's a pretty good time frame, 2011 to through 2018. So a pretty good time frame as far as the individuals. And we were looking to see the proportion of individuals with at least one criminal justice system encounter, so that reads as an arrest, going to jail, within 6 months before and after the start of a long-acting injectable, within 12 months before and after the start of the long-acting injectable, again, compared to people on orals, and actually within 2 years. I didn't get that on the, again, didn't make it on the slide apparently. So we looked at that. It's a very straightforward intent to treat analysis. So we went with, if CSS decided to treat them, that we went with their clinical decision. We're not going to go back and second guess all of that. We ended up from that time frame, 975 patients, which is a pretty good number. And CSS was designed way back, or I think 1988, 89, to particularly treat individuals in Summit County who have serious and persistent mental illness. So there's a reason for that. You would not see this number, for example, at Portage Path. We've got some excellent nurse practitioners on today from there, psychiatric nurse practitioners. So they would not see this number in that time frame on long-acting injectables. So we chose CSS for this. And you can see here the male and female ratios and so forth, just to give you a sense of what that was. Notice that about 59% were on Invega Sustenna. The rest were on different long-acting injectables from that grid that I showed you. And you'll see here that you always want a P less than 0.05. The ones we saw as significant here were much more significant than that. Sorry about that. Were much more significant than that in terms of what we're looking for. So it's easier to show you with pictures. So you can see here, this is the 6-month grid, 6 months before and after starting it. You'll see overall, there was a significant difference no matter what the long-acting injectable was. And in terms of, again, criminal justice system encounters, you'll see that here we are with the paliperidone. You can see risperidone, Haldol. Although not as many people, you can still see a difference, not significant because of the p-value, but still you're seeing that. Even flufenazine, which is used a lot less in America at this point, and then aripiprazole, which there are two types, as I showed you on the grid, for the long-acting injectable. This gives you then 12 months, right? Same thing. Now notice now a much bigger significance here, particularly with the Invega Sustenna, the paliperidone. You'll notice here that some of the other ones start to approximate it, Haldol. Dr. Messamore and I looked at this together, and he was like, yeah, you know, what if you had twice as many? We don't know. Obviously, we can't predict whether or not Haldol would become significant once you've got many more patients, because you'll see here 93. I'm sorry, this should not say paliperidone. This should be over here. This is overall. Paliperidone should be here. So you'll notice a 574 versus 93. So very different in terms of how many people, the power of the study for that purpose. But this gives you the actual more raw data for those same outcomes. And then we looked at, so then, again, I already said this, overall, there is a significant reduction in the risk for criminal justice system encounters before and after at 6 and at 12 months. And so this included people that either had never been arrested, and then we show that they have less likelihood of arrest later, or they've already been arrested. They also show less likelihood of arrest later once they've started the long-acting injectable antipsychotic. This is, I just put this in so you can see our partners here, I'll show you now the 2-year data. But Dr. Bada is the lead person who is doing the statistics with soon to be Dr. Bista. We've got individuals from Janssen Scientific, and I should say, just as the disclaimer, they did give some funding for the study, which we basically passed on to Kent State for their purposes, but they never, ever saw the data, touched the data. It was all Kent State, just to be clear that it was not somehow a drug company study. And then Eric Hutzel, who's actually now gone to the Cleveland Clinic, but he and I coming in there from the Summit County ADM board. So prettier pictures that I drew from some of our posters that we presented on this. But you can see here again the risk reduction in terms of people. This is a 1-year example, and big differences here. I mean, this is really quite a difference in terms of the number who are arrested before. You can sort of see here, hey, these people are free in a sense a year later, but 30 are rearrested. So that's kind of the idea of the graphic here. And then 86 are free of the 132, 46 are rearrested. So huge difference in the number of people who end up having a new or a second arrest. And then at 2 years, same idea, not quite as strong, interestingly. 6 months, 1 year was better than 6 months. The 2-year mark, you start to see still more than a 50% reduction. But this is any long-acting injectable, and this is Invega Sustenna. We broke that out because it was the highest percentage of people that received that particular medication. So we've seen this significant reduction in those. So you add that to the other studies that are showing you decreased risk of relapse, decreased risk of hospitalization. Some others that showed up positive and significant, although the meta-analysis only showed those two first things. And we see as we move into mortality, that was a decreased risk of all-cause mortality as well as death by suicide mortality. And here we see the decreased risk of criminal justice system encounters. So it's a pretty big difference here with long-acting injectables. And there is with these studies, especially now newer ones, all the ones I've shown you are very recent, there will certainly be more of a push nationally to see more people, again, first tested on oral antipsychotics, make sure they work. It's not like you just start hitting people with long-acting injectables. You need to know that it's going to work. But overall, once they've shifted from an oral that's working, they do better once they're on their long-acting injectable. The other piece I wanted to mention today, and I think it was in the title anyway that Jamie sent out, is this family relationship piece, and really also with the caretakers and care providers, is that when somebody ends up on a long-acting injectable antipsychotic, it often changes the dynamic for the better with the family in particular. I'm going to use family broadly, whoever the supportive individuals are in that person's life. I'll say Mr. Jones. So if Mr. Jones is going along and then doesn't do well today, the very first thing, and this that we've talked to NAMI about, that's in other groups, the very first thing that happens, which is always a fight, verbal usually, although sometimes physical altercations occur, is, did you take your medication? Right? If Mr. Jones is not having a good day, it's raining out. He was hoping to go to I don't know, a grand opening of a pool in some community, which I think probably would have all happened today around Ohio, but probably won't. He was hoping to do. He's just not happy. Well, the first thing that he gets asked is, did you take your medication today? That is not the first thing that would get asked if it was somebody not known to have an illness and be taking your medication. So that becomes a fight, and of course, that doesn't help anybody if they kind of are treated like they're always a patient, always on medication, and without medications, they may interpret it as they're somehow a lousy person, right? That's not a positive. Similarly, if the family brings Mr. Jones in because he hasn't had a very good few days here, and they manage to get him in quickly, what happens? Well, guess what? All of us on this echo will ask the same questions. Did you take your medication? It becomes the same wedge between us and the therapeutic alliance that we heard a lot of good things about last week from Dr. Welton. I actually wasn't present, but I did watch it on the Neomed YouTube channel actually this morning. So yeah, that same idea, that therapeutic alliance is very important. When you have the long-acting injectable in place, what we've heard from those supportive family members, we've heard from a number of psychiatrists, psychiatric nurse practitioners, social workers, et cetera, on the teams, is that it takes them a little time to stop asking, or at least to stop beginning to ask, did you take your medication? Because now Mr. Jones is allowed to have a bad day. And guess what? We all have bad days. So it starts to actually more normalize Mr. Jones for the family and for his treatment team. And that outcome can be huge in terms of changing this for the positive, in terms of shared decision making and so forth. And that I suspect is partly also what Judge Stormer, just to come full circle to that, probably is noticing in those individuals is they have a better relationship with everybody who's in their lives because they're no longer fighting about medications all the time. Right? You got your shot 3 months ago. We don't have to think about it now, right? Assuming it was working and there's no huge new stressors, because new stressors can exacerbate anybody's illness. We've seen that in COVID with increases in anxiety and depression and other illnesses. So I just wanted to emphasize that because I don't hear that talked about. I've not seen any. I did look. I've not seen any studies about that. That would probably be more of a qualitative than what I showed you were all quantitative studies. But I think that a nice qualitative study on that would be awesome to show that advantage for NAMI, for family members, for all providers, and so forth. And I will take questions.